It's live, ma'am.
Hi, everybody, and a very, very good evening. It gives me great pleasure to welcome you to the fourth module of systemic endocrinology on a very, very difficult topic, vision and endocrinology. And we have a very, very exciting panel today, and I'm sure this is going to be another hour of great learning. It gives me great pleasure to introduce the two chairpersons, Dr. Sumit Khanduja from Karnal, who is currently faculty and HOD, Kalpana Chawla Government Medical College, Karnal, and Dr. Zahir Abbas, who is the consultant phaco and vitreoretinal surgeon, Apollo Medical Center from Kolkata. Really looking forward to hear their inputs. Looking forward to a very, very fantastic session from Dr. Sengupta. And I will now hand over the proceedings to Dr. Zahir Abbas to take it forward from here. Over to you, Dr. Zahir Abbas.
Yeah, good afternoon, everybody. So I think we will be starting with the quiz or with Dr. Nilajin's presentation. Rahul?
We'll be starting with the quiz, sir.
Okay, so Dr. Rahul is currently the senior resident, Department of Endocrinology, NRS Medical College, and he has a lot of honors and awards. He is the gold medalist on DM Endocrinology 2020 and passed special certificate examination in the endocrinology and diabetics conducted by the Royal College of Physicians in 2021. He has also a lot of presentations and has 5 publications in indexed and national and international journals. So over to you, Rahul. Now I can start the quiz.
Thank you, sir. I'll just share my slides. Is my slide visible?
Yes, it is visible.
Good afternoon, everybody. So I'm going to take you through the quiz of this session. First of all, I would like to thank the Endocrine Society of India for giving me this opportunity. This is my first time as a quiz master. So I have compiled all the questions with the help of Professor Nilajin Sengupta, sir. And there are easy as well as tough questions. So I hope it will be an interesting session. So before we start, I'll just like to go through the rules. So there'll be a total of 10 multiple choice questions. And after I finish reading the questions, I'll give a 20 seconds time so that you can go through the questions properly. After each question will have 1 mark each, and there are no negatives. And I request all of you to give the answers compiled together in the chat box at the end of the quiz. If you have logged in with your device name or short name, you just make sure that with your answers, you give your full name and the city. And after the quiz is completed, I want all the answers within 2 minutes of completion. And in case there's a tie, the person who has sent the answers initially or the earliest will be considered. And the answers and the winners will be given at the end of the session. So let us begin. So question 1. All of the following are true about optic pathway glioma in neurofibromatosis 1, except option A, it is a slow growing tumor with less chance of malignancy. Second option is it is seen in approximately 50 to 20% of children with neurofibromatosis 1. Option C is they are usually asymptomatic. Option D is the usual age of onset is more than 10 years. So I'll give you 15 to 20 seconds. Okay, coming to the next question. Angioid streaks are seen in all except Addison's disease, Ehlers-Danlos syndrome, acromegaly, or diabetes mellitus. Angioid streaks are seen in all except Addison's disease, Ehlers-Danlos syndrome, acromegaly, or diabetes mellitus. Coming to the next question. This is a long question, so read carefully. Pituitary tumor compressing on the right Willebrand's knee of the optic chiasma typically results in which field defect? Option A is contralateral central scotoma with ipsilateral inferotemporal quadrantenopia. Option B is ipsilateral central scotoma with contralateral superotemporal quadrantenopia. Option C is ipsilateral central scotoma with contralateral inferotemporal quadrantenopia. And option D is contralateral central scotoma with ipsilateral superotemporal quadrantenopia. So I'll give you some extra time so that you can read it carefully. Okay, coming to the next question. All of the following is associated with pigmentary retinopathy except option A is Cockayne syndrome, option B is Asher's syndrome, option C is Bardet-Biedl syndrome, and option D is Kern-Serre syndrome. Okay, coming to the next question. All of the following are true about Ectopia lentis in Marfan syndrome except option A is Ectopia lentis is seen in 20 to 30% of the people. Option B is it is typically bilateral. Option C is lens is dislocated superotemporally. And option D is it is due to abnormal fibrillin fibers and proteolytic degeneration of the fibrillin-rich microfibrils. So all of the following are true about Ectopia lentis in Marfan syndrome except. Coming to the next question. What procedure has been done in this photograph? Is it A, pan-retinal photocoagulation? Is it B, macular grid photocoagulation? Is it C, focal photocoagulation? Or is it D, photodynamic therapy? What procedure has been done in this fundus photograph? Coming to the next one. Option 7. So you have to identify what instrument this is. Is it a Hertel's exophthalmometer? Is it a Naugle's exophthalmometer? Or is it a Loede's exophthalmometer? Or is it none of the above? Take a close look at the picture. Coming to the next one. Which of the following is true regarding definition of clinically significant macular edema? So option A is retinal thickening at or within 1500 micrometer of the center of the macula. Hard exudates at or within 1500 micrometer of the center of the macula if associated with adjacent retinal thickening. C, zone or zone of retinal thickening, one disc area in size, or at least part of which is within one disc diameter of the center of the macula. And option D is none of the above. Okay, read the options carefully. Which of the following is true regarding the definition of clinically significant macular edema? Okay, the next one. First of all, you have to identify what this picture is, this photograph is, and this condition is seen in all except CRVO, diabetic retinopathy, CRAO, or iridocorneal endothelial syndrome? So this is a tricky question. First of all, you have to identify what it is. And this condition is seen in all except CRVO, diabetic retinopathy, CRAO, and iridocorneal endothelial syndrome. Take a good look at the picture. Okay, now the final question. All are true regarding von Hippel-Lindau's disease except option A, VHL tumor suppressor gene is located on chromosome 17q11.2. The CNS hemangioblastoma is the most common tumor seen in VHL. Pheochromocytoma in VHL predominantly secretes norepinephrine. Annual screening for retinal hemangioblastoma should start from 1 year of age. So which of these options, all of these options are true for VHL except? Okay, so that comes to the end of our quiz. All of you, please send in your answers soon. In my laptop, the time is 4:11. So up to 4:13, I will be taking the answers. Following that, I will not be taking the answers. So send all the answers compiled together. Shall I stop sharing my screen? The answers I will discuss after the next session. All the answers, and I will tabulate the answers, and then we'll discuss.
Okay, I have the pleasure to introduce Professor Nilajin Sengupta. He is the head of the Department of Endocrinology, NRS Medical College and Hospital, and he's also the honorary general secretary of Endocrine Society of Bengal. He's on the National Advisory Board member of the Indian Journal of Endocrinology and Metabolism. He's also a secretary board of studies in the Endocrinology, West Bengal University of Health Sciences. He is the coordinator DDDC course state medical faculty and has more than 75 publications in national and international journals. So today's topic is vision in endocrinology. Now over to Professor Nilajin Sengupta. Sir, please start. Sir, you are muted. Yeah.
Am I audible now? Yeah. Thank you.
Yes.
Thank you, Chairperson, sir. And I thank ESI, Dr. Shaptarshi, Dr. Shaila for considering me for this onerous job of addressing particularly a knowledgeable, erudite audience of the endocrine and ophthalmology fraternity with a rather difficult topic, a vision in endocrinology. Trying to prepare the lecture, what I found that visual problems in endocrinology is not equal to diabetic retinopathy and cataract, which of course are the two most common visual problems that we encounter in endocrine practice, but probably every endocrine disease directly or indirectly may affect vision. But since diabetes is the most common and the most important cause of visual morbidity, if that is untreated or uncared for, I will devote a significant amount of time to diabetic eye disease. Now, what can cause visual loss in diabetes? We all know cataract, glaucoma, diabetic macular edema, diabetic retinopathy, especially the complications of diabetic retinopathy like vitreous hemorrhage and retinal detachment, even severe proliferative diabetic retinopathy may not lead to any visual loss, and retinal venous occlusion, arterial occlusion, branch vein occlusion, etc., are also more common in a patient with diabetes as compared to the general population, simply because diabetes is a pro-thrombotic state. And one of the most serious complications of, I think that has been in the quiz, probably now I can give out the answer, because I think they have all given the answer. One of the serious complications of diabetic retinopathy is rubeosis iridis, which can cause neovascular glaucoma. So cataract is 2 to 5 times more common in patients with diabetes than without. And diabetic cataract may be of 3 types. The accelerated senile cataract, that is common. We have patients who are having type 2 diabetes develop senile cataract on an average a decade earlier than their non-diabetic counterparts. Especially in type 1 diabetes, periods of poor glycemic control are associated with snowflake cataract, which may be partially reversible with good glycemic control, and also there may be posterior subcapsular cataract. And after certain surgeries, notably cataract extraction, complications of cataract extraction, though generally are rare in good hands these days, but still these complications are more common in patients with diabetes, like pseudophakic cystoid macular edema or certain deterioration in the retinopathy grades following ocular surgery. Now, very briefly, the etiopathogenesis of diabetic cataract. Here, the polyol pathway is invoked. There is increased activity of aldose reductase because of the hyperglycemia, which leads to activation of the polyol pathway, and sorbitol accumulates inside the lens, which actually contributes to opacification of the lens. At the same time, there is formation of advanced glycation end products. So these are the 2 main things, that is the activation of the polyol pathway and formation of advanced glycation end products, which actually change the quality and nature of the lens proteins, leading to opacification. Glaucoma. Now, there has been an association between type 2 diabetes and primary open angle glaucoma, meaning that patients with diabetes are more prone to develop open angle glaucoma compared to their non-diabetic counterparts. But whether there is any direct causal relation can be debated hours on end. Again, in glaucoma, the deranged metabolic milieu of diabetes is responsible for this increase in the intraocular pressure. The most important being hyperglycemia of the aqueous humor leads to increased synthesis and accumulation of fibronectin in the trabecular meshwork. This depletes the trabecular meshwork cells and impairs drainage of aqueous, leading to increase in the intraocular tension. That apart, vascular dysregulation, oxidative stress, inflammation, reactive gliosis, formation of advanced glycation end products, as well as the polyol pathway have been invoked in the causation of glaucoma, as in other etiology of diabetic retinopathy. Diabetic retinopathy is, I think, the most discussed ocular complication of diabetes. It can occur in up to 50 to 60% patients of type 2 diabetes, and depending upon the duration, can occur in up to 90% in patients of type 1 diabetes. The risk factors are many. apart from hyperglycemia. So hyperglycemia, chronic hyperglycemia is not the sole risk factor for diabetic retinopathy. Uncontrolled hypertension, dyslipidemia, duration of diabetes itself, and as I have said, cataract surgery can worsen, it can lead to the complications of cataract surgery, which are more manifest in patients with diabetes than without, nephropathy, pregnancy and puberty, and interestingly, attempts at rapid control of glycemia can temporarily worsen retinopathy grades, as was seen in the DCCT and maybe also in the ETDRS. So, but as I would like to say, all diabetic retinopathies will not cause visual abnormalities, as in mild non-proliferative diabetic retinopathy, or even severe proliferative diabetic retinopathy, that is, neovascularization on the disc even may not cause visual abnormality, only when this leads to a vitreous, a tractional retinal detachment, or a vitreous hemorrhage, or a preretinal hemorrhage, then there may be sudden acute loss of vision. So this is a message that we have to keep in mind as endocrinologists, that examination of the eyes, of the fundus, whether by the endocrinologist himself or herself, or with the help of an ophthalmologist colleague, is must on a periodic basis, even if the patient doesn't volunteer any visual symptoms. On the other hand, the diabetic macular edema of certain severity can cause visual impairment, and this has been classified as mild, moderate, and severe. And I think OCT is an important diagnostic tool to pick up our grade diabetic macular edema. So again, this is a busy slide, but actually summarizes the proposed hypothesis behind the causation of diabetic retinopathy. Two things are very important. The starting event is probably a retinal ischemia. The starting or the triggering effect, a triggering event of the retinal vascular abnormalities is microischemia. Therefore, when you treat what is the essence of treatment of panretinal photocoagulation in proliferative diabetic retinopathy? It is to decrease the panretinal photocoagulation is done to decrease the retinal ischemic burden, so that the rest of the retina is salvaged. So the triggering point may be a retinal ischemia, but then oxidative stress, and as I pointed out, formation of glycation end products and advanced glycation end products, derangements in the polyol pathway leading to accumulation of sorbitol, which is hygroscopic and mainly affects the lens, and formation of reactive oxygen species, endothelial dysfunction, increase in vascular permeability, all come into play, not to forget the role of growth factors like vascular endothelial-derived growth factors, growth hormone, and IGF-1, which is why one of the important therapies of these days is VEGF antagonism in the management of diabetic macular edema and proliferative diabetic retinopathy. Apart from laser photocoagulation, mainly what does laser photocoagulation do? In panretinal photocoagulation, they are decreasing the total retinal ischemic burden. And what do VEGF antagonism do? They actually take away the deleterious effects of these growth-promoting factors. Now, neovascular glaucoma or rubeosis iridis that is neovascularization of the iris, and invariably this accompanies neovascularization of the retina in a very florid, severe case of diabetic retinopathy, and this can block the drainage of the angle and can lead to severe form of angle closure glaucoma, new blood vessels obstructing the aqueous humor outflow, and secondary to posterior segment ischemia. And the onset is generally correlated with poor glycemic control. And I think this is one of the severest and vision-threatening complications of diabetic retinopathy. Apart from this, certain drugs used in the treatment of diabetes can cause visual abnormalities. Notably, pioglitazone or thiazolidinedione can actually aggravate macular edema. I still remember of one patient who comes to me for regular follow-up, whose diabetes, who actually had diabetes, was prescribed pioglitazone by some physician, and he attended the ophthalmologist with a sudden dimness of vision, visual acuity, and the ophthalmologist found florid macular edema, but no features of diabetic retinopathy in the periphery, and she referred the patient immediately to me. I withdrew the pioglitazone, and the ophthalmologist, of course, did whatever necessary ophthalmological treatment, and his vision improved dramatically, and now he is doing fine. Well, hydroxychloroquine is more used probably these days for COVID-19 than for diabetes, but in India, it is an approved medication for the management of diabetes, if not controlled on 2 oral agents that can cause bullseye maculopathy, which I think the ophthalmologists know much better than us, but this has also to be kept in mind. And as I have said, rapid attempt of glycemic control, especially with insulin, during pregnancy or even outside of pregnancy, can temporarily worsen retinopathy grades. So much so, the dictum is that if a patient with diabetes having florid retinopathy wants to become pregnant, one should first stabilize the retinopathy by way of intravitreal injections of bevacizumab or something like that, or laser photocoagulation, stabilize the process of retinopathy, and then ask the patient to become pregnant, whereby you need to tightly control the hyperglycemia with insulin. Now we move on to other endocrine conditions. Let's start with pituitary. Now, pituitary adenomas, the macroadenomas, can compress the optic chiasma and the optic tract because of the anatomical proximity and cause visual abnormalities. So visual acuity problems can occur in up to 15 to 85% patients of pituitary adenoma, but visual field abnormalities are more common, may occur in even up to 100% patient cases in certain cities, but that's 30 to 100%, and there may be other unspecified visual complaints. And following successful treatment, the visual recovery in the visual defect is not always 100%. It may even be less than in 50% cases, and an off-targeted radiotherapy or a mishandling of the optic apparatus during a transsphenoidal surgery can also add to the visual impairment. So microadenomas expectedly do not impact vision. Small macroadenomas, less than 2 centimeters in diameter and which are strictly intracellular, are likely to cause no visual problems. But it is the larger tumors that can cause, or that usually cause visual abnormalities. Non-functioning pituitary tumor is the commonest subtype which cause visual problems, because those who are functioning, they are detected probably much early, like a prolactinoma in female, and so they do not grow to that extent to cause visual problem. They are detected and treated much earlier than that. But a prolactinoma in male, however rare it may be, can cause visual abnormalities. What's the pathophysiology of visual defects? A little bit into the anatomy. The compression causing direct disruption of the axonal conduction, impairment of axonal flow, demyelination, and ischemia are the main causes of this visual impairment. Initially they may be reversible, but if they are long-standing, the visual changes may become permanent, and even after surgery, there may be incomplete improvement. And there may be cranial nerve palsies also, especially if the tumor invades the cavernous sinus and or compresses, which can also add to the visual problem. Now, this, this is a well-known diagram. So the optic nerve may be compressed, leading to unilateral blindness. The optic chiasma may be compressed, leading to the typical bitemporal hemianopia. If the optic tract is jeopardized, there may be homonymous hemianopia, so on and so forth. This we know. And then the question comes whether it's a prefixed chiasma or a postfixed chiasma. In about 10 to 20% cases, the chiasma may be prefixed, that is placed anteriorly, and if a tumor growing from below will compress the optic radiation, whereas and leading to contralateral hemianopia. And if it is directly above the chiasm, there will be the typical bitemporal hemianopia. And if it is post-fixed, then there would be unilateral monocular visual deficit. This is another way to show. I think there was a very good question on Wilbrand's knee issue. So I think most of you have answered it well. Compression of the Wilbrand knee will lead to ipsilateral junctional scotoma with superotemporal hemianopia. And what is Wilbrand knee? Wilbrand knee is actually, you see, this is the Wilbrand knee, which is going into from one optic tract, optic nerve through the optic chiasma, making a detour around the other optic nerve and coming out. So this is an interesting thing. Then pituitary apoplexy can lead to sudden onset visual impairment and headache, as we all know, and even lead to blindness in up to 1/3 of cases, along with ocular nerve palsies. Apart from that, acromegaly itself can cause visual impairment by increasing the corneal thickness, by causing pigmentary retinal degeneration. There may be angioid streaks. Again, there was a beautiful question on angioid streaks. Angioid streaks can occur in Paget's disease, pseudoxanthoma elasticum, Ehlers-Danlos syndrome. Diabetes may be associated with angioid streaks, lead poisoning, hypercalcemia, and also acromegaly. There may be rarely melanocytic tumors of the choroid. There may be enlargement of the extraocular muscles and increase in orbital fat, leading to proptosis, and there may be ophthalmoplegia too. But we really do not see these things that commonly in acromegaly, but this can occur, and these have been reported in literature. What is more important, probably the tumor compressing the optic chiasm, optic tract, and so on. Another very interesting ophthalmic abnormality that is an iatrogenic one is a radiation-induced optic neuropathy. This can lead to a sudden painless monocular visual loss preceded in some instances by certain monocular or binocular visual impairment that had been transient. Further deterioration can progress over weeks, and if it starts as a monoocular visual loss, that can end up in a binocular visual impairment. And the loss of visual acuity is variable. What are the risk factors? Young age, the treatment modality, and the dose of radiotherapy. So what treatment means, what type of radiation you are using, that is also important, and what is the dose of that radiation, both are important. Another very common abnormality that we encountered in endocrine workup is a septo-optic dysplasia, of which hypopituitarism is a part. The classic triad consists of optic nerve hypoplasia, pituitary hormone abnormalities, mainly commonly panhypopituitarism, and midline defects like agenesis of septum pellucidum and or calpus callosum. You see, this is a spectrum disorder. Patients may have isolated growth hormone deficiency to multiple pituitary hormone deficiency. On the other hand, so far as visual impairment is concerned, the patient may have unilateral asymptomatic optic nerve hypoplasia to complete blindness. So this is radiologic, how it looks like. That is, there is, you see, anterior pituitary hypoplasia and absent infundibulum with bilateral optic nerve hypoplasia. The posterior pituitary is ectopic, and also there is absence of septum pellucidum. Now we come to thyroid. Most important is thyroid-associated orbitopathy. About 25 to 30% patients of Graves' disease will develop Graves' orbitopathy. And you should remember that Graves' orbitopathy can be associated with thyrotoxicosis, can be associated with euthyroidism, spontaneous euthyroidism, only there may be orbitopathy with no thyroid functional abnormality, and also rarely with hypothyroidism. Second, though commonest is association with thyrotoxicosis. Second, in Graves' disease, and about 5% of patients, the orbitopathy may antedate Graves' hyperthyroidism. In a majority, 60 to 80% cases, Graves' hyperthyroidism and orbitopathy occur together, and in some around 10 to 20% cases, Graves' orbitopathy may post-date Graves' hyperthyroidism in appearance. And as you know, though both have a similar mechanism of action and mechanism of etiology, which I'll come to just in the next slide, but these two diseases can run an independent course. And another very important vision-threatening complication, apart from exposure keratitis due to severe proptosis, is a dysthyroid optic neuropathy. So there may be many visual abnormalities in dysthyroid optic neuropathy, but the visual acuity is quite often affected. You see, reduced color vision was seen in about 80% cases of definite dysthyroid optic neuropathy. Visual acuity also to similar to the tune of 80%. Optic disc swelling, optic pallor, so these are other things. But so visual dysthyroid optic neuropathy is associated with some degree of visual impairment in a large percentage of cases. What are the risk factors for thyroid-associated orbitopathy? It is more frequent in women, but mind it, severity is more in men. Though Graves' orbitopathy is more common in women, should it occur, it runs a more severe course in men. It is more frequent in Caucasians than in Asians. Age, duration, longer the duration of Graves' disease, the higher risk of tau. But having said that, I have told the two diseases may run an independent course. Smoking is a definite positive risk factor for aggravation of thyroid-associated orbitopathy. Hypothyroidism, especially iatrogenic hypothyroidism following radioiodine therapy or even surgical ablation, is an important risk factor for aggravation of thyroid-associated orbitopathy, and also radioiodine therapy itself. Therefore, in severe cases of thyroid-associated orbitopathy, radioiodine therapy is contraindicated. So this is, in short, the mechanism how the TSH receptor antibodies help in the development of thyroid-associated orbitopathy. There is actually a crosstalk between the TSH receptor antibody acting through its receptor and IGF-1 acting via the IGF-1 receptor in the orbital fibroblast. It leads to formation and deposition of adipose tissue, that is adipogenesis, leads to accumulation of hyaluronic acid, which is actually hydrophilic, and this leads to increase in the volume of the muscles, increase in the volume of the orbit, and this leads to proptosis. And if there is less proptosis, those patients are more at risk of developing dysthyroid optic neuropathy. Eventually, this inflammation may settle down on its own, leading to fibrosis when the disease becomes inactive. So this is one muscle index computation. I think this actually falls in the purview of the radiologists, who should compute this muscle index and give an idea of how severe the muscle thickening is in a particular case of thyroid-associated orbitopathy with the help of a CT scan of the orbit. If the muscle index is more than 70%, there is a high chance of dysthyroid optic neuropathy being present, because it has been seen that more than two-thirds cases of dysthyroid optic neuropathy have a muscle thickness or muscle index more than 70%, whereas if the muscle index is less than 50%, then likelihood of having dysthyroid optic neuropathy is less. Now we come to hypothyroidism. We are more concerned about thyroid eye disease in association with, that is tau, that is thyroid-associated orbitopathy, in association with hyperthyroidism, euthyroidism, or hypothyroidism, spontaneous or iatrogenic. But that apart from thyroid-associated orbitopathy, hypothyroidism per se is associated with greater incidences of cataract, xerophthalmia, corneal dystrophy, and keratoconus. This is because thyroxine is required for tear production, corneal hydration, and transparency, of course, in animal studies. Therefore, severe, long-standing, untreated primary hypothyroidism can lead to a dry eye. Now we come to gonads. There are many syndromes which may be associated with certain ocular manifestations, like Kalman syndrome may be associated with optic atrophy. Klinefelter syndrome may be associated with coloboma of the iris, microphthalmia. Everything may not lead to visual abnormality, though. Strabismus add in 49, XXXY myopia is more common. Similarly, Turner syndrome may be associated with a host of ophthalmic abnormalities. Of course, not everything will lead to visual impairment. Amblyopia will lead to visual impairment, but a partial ptosis or a mild strabismus will not. There may be an epicanthtic fold. There may be hypermetropia, and rarely keratoconus, glaucoma, cataracts, and retinal detachment may be associated with Turner syndrome. Then we come to some other syndromes like the Bardet-Biedl syndrome, which it's not a very rare disease associated with hypogonadism, central hypogonadism, polydactyly, and the retinal changes may be retinitis pigmentosa, that is pigmentary retinal degeneration. Though this is atypical retinitis pigmentosa, I think our ophthalmologist chairperson can enlighten us how to differentiate between typical retinitis pigmentosa and other pigmentary retinal disorders that we get to see in syndromes like Bardet-Biedl syndrome or the Cancer syndrome. Similarly, Prader-Willi syndrome, which is typically characterized by obesity, infantile hypotonia, and hypogonadism, short stature, can be associated with strabismus, refractive errors, even amblyopia, hypopigmentation of the iris and choroid, congenital ocular fibrosis, and ectropion uvea. Now we come to bone. In hyperparathyroidism, there may be ectopic calcification, both in hyperparathyroidism as well as hypoparathyroidism because of alteration in the calcium phosphate ratio. This can lead to choroidal calcification, retinal calcification, calcification of the eyelids, recurrent conjunctivitis. But what can actually lead to visual impairment is the band keratopathy. So this is also because of deposition of calcium in the cornea. Band keratopathy can lead to visual impairment, and treating the underlying cause of hypercalcemia almost always yields resolution of ocular symptoms unless it's very severe. Similarly, hypoparathyroidism may be associated with periorbital tetany, blepharospasm, cataract formation. Again, many of them may not lead to major visual impairment, but again, corneal opacities can be there. Nanophthalmos is associated with Kenny-Caffey syndrome, and papilledema is also not uncommon. And with hypoparathyroidism, especially following surgery, there may be rapidly progressive corneal opacity. Macular syndrome, which we know is characterized by fibrous dysplasia, caffeolar spots, and gain of function mutation in the DS alpha subunit of the receptor, can be associated with visual field defects, and there may be optic nerve compression leading to optic atrophy and visual impairment. Similarly, Paget's disease is one of the causes of proptosis and optic neuropathy, and this also has been associated with angioid streaks and choroidal neovascularization. Osteogenesis imperfecta can be associated with corneal opacities, myopia, astigmatism, optic atrophy, and also the blue sclera that we typically know of or associate with. In osteopetrosis also, because of the local effect, the mechanical factors, impaired optic nerve myelination, this may result in optic atrophy, ptosis, strabismus, proptosis, and extraocular muscle palsy, as well as retinal degeneration. So next we come to adrenals. Well, glucocorticoid excess, whether it's an endogenous glucocorticoid or exogenous glucocorticoid, has been shown to be associated with two things, glaucoma and cataracts. So Glaucoma is more common with exogenous glucocorticoids because they alter the trabecular meshwork morphology and reduces aqueous humor outflow, thereby elevating the intraocular pressure. And topical glucocorticoids are mostly incriminated in causing precipitating or aggravating glaucoma, though even systemic glucocorticoids, as in anecdotal case reports, have been shown to do the same. Cataract is again more common in exogenous Cushing syndrome. Typically, this is a posterior subcapsular cataract, and this can again occur more with topical glucocorticoids being used for a long time, but can also occur, as I will show you, with systemic glucocorticoids too. Cushing syndrome is one of the causes of proptosis, probably because of retroorbital deposition of fat, and central serous chorioretinopathy can also be associated with increased glucocorticoids. So as I was saying, route of administration leading to steroid-induced glaucoma. Not only eye drops and eye ointments, not only subterranean injections or retrovalvular injections, but oral, topical skin injections, and inhalational steroids also can lead to increase in intraocular tension and precipitate glaucoma. Adrenal insufficiency, Addison's disease, or acute withdrawal of steroids can lead to papilledema. Adrenoleukodystrophy, though rare, has been typically known to be associated with optic atrophy, with impairment in visual acuity and visual fields. Then Aldroff syndrome or AAA syndrome, which is characterized by Addison's disease, alacremia, and achalasia cardia. So because of alacremia, there can be keratoconjunctivitis, sicca, even corneal melting. There may be lacrimal gland atrophy. That's actually the cause of alacremia. And there may be pupillary abnormalities too. Ultimately, can even lead to amblyopia and optic atrophy. Polyglandular autoimmune syndrome type 1 also may be associated with a host of ocular manifestations. You know, APS1, the major components are hypoparathyroidism, primary adrenal insufficiency, and mucocutaneous candidiasis. The severity of ocular manifestations is not correlated with the systemic manifestations. Though chronic keratitis occurring in about a quarter of patients is the commonest and most typical ocular abnormality, other heterogeneous ocular abnormalities can occur, and this is because the corneal affection is probably because of an autoimmune attack against the corneal epithelium. There is a poor genotype-phenotype correlation, and the prognosis is also poor. So apart from keratopathy, there may be other ocular manifestations, which of course are rarer than keratopathy. That may be retinopathy, pigmentary, including a pigmentary retinopathy, and others like a dry eye, cataract, iridociclitis, retinal detachment, and optic atrophy. So this is actually the example of a keratopathy in APS type 1, and this is even after the corneal transplant. The transplanted cornea also have become opacified. Pheochromocytoma can be associated with hypertensive retinopathy as a complication of untreated hypertension, but the von Hippel-Lindau syndrome has been associated with typically retinal hemangioblastoma, which is usually present bilaterally. And the proposed mechanism, exact mechanism is not known, but one proposed mechanism is increased expression of certain growth factors like vascular endothelium-derived growth factors, platelet-derived growth factor, and transforming growth factor alpha because of a lack of protein, that is PVHL, that leads to this tumorigenesis. In men to be may be associated with prominent corneal nerves, eyelid and conjunctival neuromas, because a huge neuroma simply by pressure effect can cause visual abnormalities, and rarely there may be choroidal metastasis from a medullary thyroid carcinoma. Neurofibromatosis again may be associated with a host of ocular manifestations like the leash nodules, which are nothing but hematomas in the iris, may be associated with the glaucoma, and most important is an optic nerve glaucoma. I think we had an excellent quiz question on optic nerve glaucoma. Mind it, only 20 to 30% are symptomatic. So optic nerve glaucoma may be asymptomatic too, can present with planeless proptosis with or without visual impairment. So 15 to 40% of children with neurofibromatosis 1 have optic nerve glaucoma. Some of these lesions are asymptomatic, that is, not all are symptomatic. Bilateral optic nerve glaucomas are almost pathognomonic for neurofibromatosis 1, and unilateral decreased visual acuity with relative afferent pupillary defect may occur. So leash nodules, we have.
Dr. Nilajin, I'm very sorry to interrupt. We have.
Okay, so I'll winding up in 1 minute.
Yeah.
Benign
sorry. It's a lovely, so much of learning, but I wish I had more time. That's all. So sorry.
Benign hematomas and other ocular endocrine syndromes that I think I have alluded to: cancer, Didmouth syndrome, Usher, Cockayne, and Werner syndromes. To conclude, therefore, though our bread and butter would be diabetic retinopathy and cataract and thyroid associated orbitopathy, as well as a pituitary, hypothalamo-pituitary SOL causing visual problems, we have to keep in mind that virtually any endocrine disease can directly or indirectly impact vision, and we must have a high index of suspicion. And needless to say, we need to have a collaborative clinical approach for uncovering these visual problems and addressing them where possible. Thank you. Thank you for the opportunity.
Thank you, Professor Nilajin, for an excellent in-depth presentation. So I had some points to discuss. I don't know whether we'll be getting the time or not.
So you can please go ahead, Dr. Zahir, not a problem. Please go ahead.
Okay, one of the burning issues we as ophthalmologists face is that many a time patients are consulting doctors, but when they maybe they verbally tell the patients to get consultation with a ophthalmologist for a retina diabetic retinopathy checkup, but often they don't get it done. When we ask them कि आपको डॉक्टर साहब ने बताया नहीं कि आपका आंख भी दिखाना है, अभी आप पा रहे आपका इतना खराब हो गया है, so much of damage already done, so they often deny that we have not been told. So I think one message that we want to create between us and all of us, that we have to ensure on writing that diabetic retinopathy screening, and in the next visit they should tell us that what is the report of that, because if you don't insist, they will not come to us for checkup, and often they land up with a proliferative diabetic retinopathy, because even we have seen cases of advanced PDR, there is neovascularization elsewhere, patient has 6/9 vision, and by the time we do something to it, there is already hemorrhage, tractional detachment setting in. And the most of the worst diabetic retinopathies, proliferative retinopathies, are happening in the 35 to 45, 50 age groups. Beyond that, it is not that severe, but in this age group, the proliferation part is very severe. And if not tackled previously, if you don't do laser previously, it's a very bad situation. And just direct ophthalmoscopy is always not enough to pick up subtle neovascularizations in the mid periphery region. If the patient is not cooperative, that we may miss. So that is one thing. And secondly, that regarding diabetes control and our surgery, cataract surgery, retina surgery, or intravitreal injections. So this is another gray area. Often us ophthalmologists, they ask for absolute controls, which practically is not possible for diabetics. That is something also which we both should agree, that at times a little bit of sugar here and there is acceptable, because if you do too much of a tight control, patient can land up with hypoglycemia, and that can be even more dangerous for the patient. So that is something which also I wanted your opinion, Professor Nilajin and Dr. Rahul. And just 2 days back, I came across a patient, retina detachment happening from diabetes, from tractional retinal tractional retinal detachment. And when I asked them to come up with the sugar reports, the PP sugar is 500 plus, fasting sugar is 300 plus. Now, how do we proceed after this? Do we need insulin to rapidly control the sugar? Because the detachment part is, we have to tackle it as early as possible. So this is something.
Yeah, Dr. Abbas, your points are perfectly well taken. I do 3 things when I refer to an ophthalmologist colleague. First, I explain why they need to check up. Even if you do not have visual problems, you have to do it, because they think that I did a microsurgery 2 years back and that was excellent. So as if everything has been done just because phacoemulsification has been done. They think that. So we have to make them understand. I document it. And in the next visit, I think 80% will not come with an ophthalmology record. In the next visit, I inquire that, have you done it? And again, if not done, I say, again, write and again say. That's what we can
that is very important.
Impress upon them the importance of a visit to an ophthalmologist. Next thing, what you said about the glycemic control. If you have a tractional retinal detachment, of course, that is a semi-emergency, I would like to say. You would love to operate within, say, 7 days or 15 days. So with a 500 plus, I think you have to optimize the glycemia with insulin. Then don't be bothered about temporary worsening of retinal traits, because already he had an advanced eye disease. It will not worsen further. So you have to go for hypoglycemia. And Rahul, would you answer what to do for a DFA or a cataract or maybe a laser photocoagulation?
Most importantly, DFA and this angiography and creatinine, sugar and creatinine levels pre-angiography. This is some gray area also, because often we tend to say your sugar levels are very high. But if we see, will there be any harm if you do with a little bit higher sugar levels? And what would be the cutoff creatinine level for doing an angiography, fluorescein angiography?
Usually for an angiography and for panretinal photocoagulation, we do need a glycemic control. We usually optimize with oral anti-diabetic agents. So preferably you need a fasting of around 120 to 140 and a PP at least less than 200. That is what we usually do in our OPD basis. Apart from that, creatinine, usually an advanced renal disease, the thing is, most of these patients will also have a renal disease, like you have seen. Advanced renal disease, we will be a little more cautious.
2.5
we calculate the EGFR. EGFR, if it is usually above 45, there is no specific recommendation regarding this. Usually above 45, then you can go ahead and do it. And below that, again, we should be more cautious. Although these are not from recommendations that
it's still not an absolute contraindication to giving fluorescein. So only the excretion would be delayed. That's it.
That's it. Yes, that is what also. Achha, one more important fact which I had come across by consulting with another endocrinologist is timing of the antihypertensive dose and a patient who has diabetes and glaucoma, diabetes, hypertension and glaucoma. Because what is the problem with glaucoma patients is, if the blood pressure drops too low at night, it can have deleterious impact on the optic nerve glaucomatous progression. That means a very low BP at night can lead to progression of glaucoma. On the other hand, maybe for the heart and all, a very low BP at night is good for the heart. So this is something to contradicting situation that we are facing. So what is your take on that?
Well, this is a nocturnal dipping and an early morning rise. Now has been now a trend towards giving more of the antihypertensives in the evening or night because of that, to simulate that nocturnal dipper and the overshoot in the morning. But then, mind it, most of the antihypertensives used these days are long-acting ones. It hardly makes any difference whether you give the ARB S inhibitor or a long-acting calcium channel blocker at night or in the morning. It hardly makes any difference. So that's it. What I do, if I have to give more than one antihypertensive, I give one in the morning and one at night to have a more smooth control. So just as you should not be unduly scared of a blood pressure dipping with these antihypertensive agents, if they're used rationally, there should not be precipitous hypotension. If they're used rationally, that's the caveat. And at the same time, the cardiologist also should not be too much bothered if the antihypertensive is prescribed in the morning. It is the overall 24-hour control that matters.
That matters. Okay. And one more point regarding the pituitary tumors and field defects. Most of these cases that I have come across is, please help me understand, that most of them had visual field defects, but rarely these patients had complained of hormonal problems. On the other hand, those who had pituitary hormonal problems, they did not quite complain of field defects initially. So why is this?
Well, the answer lies in your question, Rahul. It's an easy question for you.
That's the thing. When the tumor is secreting hormone, they present earlier. So the size of the tumor will be smaller, especially like in Cushing's disease. Usually the size of the tumor is small, so it's picked up early. So the larger tumor like acromegaly and non-functioning pituitary adenoma, they're so slow growing and they present very, very late. So because of that, the tumor size is already so big that it compresses the optic chiasma.
But so they don't have hormonal problems.
No, because there may be different types of pituitary tumors. Some are secreting, some are non-secreting. The non-secreting tumors are silent. They do not have any biochemical or clinical manifestations. So they grow up to a big size and compress the surrounding structures. Whereas a functionally active tumor,
they are identified early.
The typical example is prolactinoma. Prolactinoma in female is almost always a microprolactinoma or a small macroadenoma with galactorrhea. But a prolactinoma in male, since that doesn't lead to galactorrhea in males is very rare, extremely rare. Only if there is underlying gynecomastia too. So that's why they are big tumors with local compressive features are much more big.
Much more, okay.
Yeah, sir, I had one or two submissions.
Yeah.
So first was regarding the screening for, the referral for diabetic retinopathy by endocrinologists. So often we find that, many endocrinologists till now and many general physicians still saying that if your visual acuity is okay, you need not get a diabetic retinopathy screening done. So just for the information of all, 30% of patients who have proliferated diabetic retinopathy, they have 6/6 vision till they get their first bleed. They do not have macular edema. So this is one thing that's very important for everyone to learn, that patients can go into proliferated diabetic retinopathy and yet have 6/6 vision. The second is, there has been a recent popularity of non-mydriatic fundus cameras, which we find many physicians, adopting in their practice. So I would like to say that, these non-mydriatic fundus cameras, yes, you can use them if you know what is the limitation of that. They are more helpful in ruling in the disease rather than ruling out. If you cannot see a hemorrhage or an exudate on your non-mydriatic fundus camera image, that doesn't mean that the patient does not have diabetic retinopathy. So that is the second thing, because we see a lot of endocrinologists, they have they have taken they have purchased non-mediatic fundus cameras, and they have stopped referring people for retinopathy evaluation. Then, so the third issue was what Dr. Abbas, Dr. Zahir said, was regarding the pituitary adenomas. That is, of course, there's a difference of non-secretory versus secretory adenomas. It also came as a result of a doctoral thesis which was done in API Center AIMS, that those patients of who are being taken up for surgery for pituitary tumors and have got bitemporal hemianopia, in that you do an OCT, that is an optical coherence tomography of the retinal nerve fiber layer thickness, right? And you have to see what is the thickness in the nasal quadrants. And if the thickness is normal, then the chances of the recovery in terms of the defect, the visual field defect is very high. So you can refer your, for especially neurosurgeons or those of you who are encountering such patients, that a pre-operative OCT of the optic nerve fiber can help you prognosticate patients who are being taken up for these adenoma surgeries. So that was it. As in for Dr. Rahul's thing, that and Dr. Zahir's concern, that if you have a patient of tractional detachment, yes, Dr. Zahir, tractional retinal detachment is not a surgical emergency, it may be an urgency, but yes, if you have a combined rheumatogenic retinal detachment and you have a patient whose blood sugar is 500 and you want to take him up, the answer from my side or what I practice is that yes, you take him up, control him for insulin. It's just like that if a patient needs an emergency laparotomy and he has a blood sugar of 500, you will not wait for 48 hours, 72 hours for the blood sugar to normalize. You will involve your physician to control his blood sugar and at the same time take him up for surgery. So if the situation arises that you have an ophthalmic emergency, you will have to take the help of your colleague, control the blood sugar and without delaying the surgery. So that was my point, sir.
Yes, yeah.
Can we have the answers to the quiz? I mean, can we have the quiz and the answers to the quiz, Rahul?
Yes, I'm just sharing my slides. So we'll quickly go through the answers. So most of it has already been discussed by sir. So the first one was, which of the following is true about optic pathway glioma in neurofibromatosis, except, so optic pathway glioma is a slow growing tumor with less chance of malignancy. That is the correct answer. And it is seen in around 15 to 20% of children with neurofibromatosis 1. Usually they are asymptomatic, only around 30% are symptomatic. And the usual age of onset is less than 6 years. The mean age of diagnosis is around 4 years. So because of that, you have to start screening from 1 year of age, and which has to be done annually. Angioid streaks are seen in all except, so this also has been discussed by sir, it is not seen in Addison's disease. So what are angioid streaks? They are breaks in the Bruch membrane. So this can get aggravated and again can cause bleeding, and it can cause retinal detachment also. So Addison's disease is the wrong answer. So this also was discussed by sir. It was a little confusing, but if you know your anatomy well, then you can easily pick up the answer. So pituitary tumor compressing the right Wilbran's knee will cause what field defect? Like sir said, it is a junctional scotoma. So you will have an ipsilateral central scotoma, because then the fibers from the contralateral, what is Wilbran's knee? The fibers from the contralateral side, the nasal retina is crossing to the inferior nasal retina is crossing to the opposite side and taking a bend. So because of that, when there's a tumor on one side, you will have a contralateral superotemporal quadrantinopia with a ipsilateral central scotoma, also called a junctional scotoma. Question 4, what all are associated with pigmentary retinopathy except? So the answer in this is Usher syndrome. Again, it was discussed by sir. Usher syndrome is again a rare disease which is associated with intermittent swelling of the eyelids, also called blepharochalasis, with it typically has a double upper lip, and also a non-toxic goiter can be associated. The other conditions, Bardet beetle, Kern's hairs, and Cockayne syndrome can be associated with pigmentary retinopathy. Question 5, Ectopia lentis is seen in, that all are true about Ectopia lentis in Marfan's except. So Ectopia lentis is one of the most common ophthalmological manifestation of Marfan, seen in around 60 to 80% of the patients. Again, it is typically bilateral with a supratemporal dislocation, and it is due to the fibrillin FBN1 gene mutation. So what is this procedure which has been done? This is a macular grid photocoagulation, which is typically done for macular edema. Pan-retinal photocoagulation is typically done for proliferative diabetic retinopathy and very severe non-proliferative diabetic retinopathy. Photocoagulation, focal photocoagulation is done just for the small leaking microaneurysms, which is done at different foci. And photodynamic therapy is done mainly for age-related macular degeneration and choroidal neovascularization. It is done. And what is this? This is a Nagel's exophthalmometer. So the advantage of this exophthalmometer is it can be used for patients who have undergone orbital decompression. So the Hertel's and the Lloyd's exophthalmometer, you need the lateral orbital rim is required for the measurement of the amount of proptosis. This one uses the superior and inferior orbital rims. So it is easier to calculate in post-op patients who have undergone a orbital decompression surgery. Question 8, again, I think it was somewhat a theoretical question. So this one, the retinal thickening at or within 500 micrometers is the correct answer for A and B. Both are, it's not 1500, it is 500. And option C is the correct option. So that is the answer. Zone of retinal thickness within one disc area in size, or at least part of which is within one disc diameter of the center of the macula. Option 9, so this is a iris neovascularization or rubeosis iridis. So, so the thing is, it is seen in conditions when there is hypoxia and ischemia. So CRVO, diabetic retinopathy, and CRAO is associated with iris neovascularization. Iridocorneal endothelium syndrome is a condition which causes secondary glaucoma due to a formation of the membrane at the outlet of the where the aqueous humor exits. So it can cause a secondary glaucoma, but it does not cause iris neovascularization. And option 10, the last one is VHL tumor suppression gene is actually located on chromosome 3. That is the short arm of chromosome 3. And all the other options are correct. That is CNS hemangioblastoma is the most common tumor. The pheochromocytoma secretes norepinephrine, and annual screening should start again from 1 year of age. It should be done annually. So those are the answers. So I have the winners. So one second. So the first prize goes to Dr. Piaz Gargari. He is from Kolkata. He has got 9 out of the 10 answers correct. So that congratulations, that is an amazing performance. Second prize goes to Dr. Sandeep Kumar. I don't know where he is from. He is not written in. And the third prize goes to Dr. Pankaj Patwari. He is from Kolkata. So congratulations to all the winners.
Rahul, you didn't leak the answers now? Both are from Kolkata.
Oh no, they are not from my college.
I'm just joking, just pulling your leg, relax. I know that's not possible. Just adding some humor. That was a fantastic 1 hour of learning, or more than 1 hour actually. Thanks, Dr. Sengupta. That was really fantastic. I've always known that the eye is, they say, the soul of your, reflection of your soul. Today I realized that the eye is so much more than just a reflection of the soul, to be honest. Dr. Abbas and Dr. Vijay, thank you very much for sparing your time. We as endocrinologists will definitely see to that we are more emphatic, that we follow up once we ask our patients to do a referral. We don't simply let it go and ask them again, did you see the ophthalmologist or not? So that's the advantage of these interdisciplinary meetings. We learn from you all. And hopefully we have also been able to share some of our knowledge with the two stalwarts like yours.
Sure.
A big thank you on behalf of ESI for spending a precious time with us on a Sunday evening. Thank you very much. Thanks to everybody who logged in, and a big congratulations to all the winners. That was a tough quiz out there. Thank you very, very much, and have a great evening, everybody.
Thanks for
Thank
the
you.
honor.